Hello, everyone, and welcome to this week's lecture on health inequalities, environmental racism, and environmental justice. The learning goals for this week are: what is the history of health disparities in the United States? How do health disparities in the United States today vary by race and ethnicity? How can we explain health disparities, and what are the effects of environmental racism? So the reading began with the history of health disparities in the United States, giving us some examples of how African Americans in particular have been mistreated, abused, experimented on by doctors and the medical fields. One example was James Marion Sims, sometimes called the father of American gynecology, used involuntary subjects, many of them enslaved African Americans, for experiments, and the reading described the brutal ways in which the women were treated for his experiments. The reading also talked about the experimental use of radiation in 1945. And eventually these experimentations led to the Nuremberg Code, a policy adapted in 1953 under which research subjects have to be informed that participation in is voluntary and be provided with information about the nature, duration, and purpose of the research. So we can understand with this history why many people of color are suspicious of the medical personnel. They don't necessarily feel comfortable going to doctors. They don't trust the medical professionals. So we can see that this comes from a long history. The reading gave us some examples also of the disparities in health. And here we have the age-adjusted death rates for all medical causes by race and Hispanic origin and sex. And here we see how African-American men in particular have a higher rate of death than all other groups. Here we have a few charts showing the specifics around particular conditions. So the first chart gives us death rates of HIV. And here we see how very significantly large the numbers are for African Americans compared to other groups. Over here, we have the death rates of diabetes. And here we see that Native American populations have a very high rate in comparison to other groups. But again, we see African Americans significantly high as well. Obesity death rates, again, we see here African Americans and Native Americans having some of the highest rates. And cardiovascular disease, we see here, again, African Americans having very high rates. But we see here that for cardiovascular disease, a lot of populations, not just African Americans, have a high rate of deaths related to this particular disease. Another thing the reading talked about was the discrepancies in terms of birth weights for babies. And here we have the chart or the figure which demonstrates that African-American mothers with college degrees are more likely than whites, Hispanics, and Asians with less than a high school education to have low birth weight babies. Babies born with low birth weight are at higher risk for death. The reading also talks about, how the segregation contributes to these health disparities. And again, these were just a few of the examples of the kinds of health disparities that exist between different racial ethnic groups. And so the reading talks about this idea of racial capitalism in relation to COVID-19, but not just COVID-19. This is relevant to health disparities across different medical conditions and illnesses. So the reading talks about the scholar of the last name Pirtle, who argued that racial capitalism fundamentally influences how diseases spread and reproduce themselves. This, of course, applied to COVID as well. Those who live in racially segregated, deprived neighborhoods have less access to green spaces and are overexposed to toxins. And racial capitalism also affects access to resources, including grocery ordering services, protective equipment, information about how the disease spreads. And this is particularly relevant to COVID in terms of not having access to information about the disease, understanding the information, or having access to healthcare facilities and so on. Here we see the causes of cases and deaths of COVID. These were through December 18, 2020. This is before we had any vaccines. And so in the left there, you see the number of cases, and we see that the number of cases among Native Hawaiian, Pacific Islanders, and American Indians, Alaskan Natives were some of the highest number of cases. But then when you look at the number of deaths, African Americans had the largest number of deaths. So even though they are a large number, or among African Americans, you see that there were less number of cases of COVID by December 2020, the number of deaths was much higher than in other groups. African Americans, as we've seen in many of these examples, have some of the worst health outcomes of all groups. The question is why, right? What is contributing to this? And so we have individual racism and structural racism, again, to explain some of these things. So in terms of individual racism, when African Americans experience discrimination, their responses may include anger, resentment, fear, frustration, and other stress responses. Scientists have found that these responses cause the adrenal gland to produce hormones that inhibit immune responses and increase vulnerability to disease. Coping strategies include unhealthy responses as well, such as increased alcohol use, smoking, and overeating of fatty foods. Structural racism presents itself in some of the things we've talked about, where African Americans and Latinos are more likely to live in neighborhoods where they have less access to fresh produce, parks, jogging trails, and healthy foods, all of which are significant to battle illnesses like diabetes and cardiovascular health. Some of these other things that affect this as well is access to health insurance, access to jobs where health insurance is provided, for example. Are there clinics in their neighborhoods or easily accessible, or do they have to travel significant distance in order to get to a hospital or a health clinic? Individual forms of racism also, there are a number of studies, and just anecdotally, where people have shared where doctors feel uncomfortable touching African Americans, right? And so that is a problem, right? If you're going to examine an African American person in a clinic, you have to feel comfortable, right, with that person and be able to build a rapport of comfort and trust with that individual. And if that doctor is white, or someone who has biases, whether they're implicit biases or not, around African Americans, that African American patient is not going to get the same kind of care as some other groups. So there are a number of things that contribute to these health disparities that we are seeing. The reading also talked about this idea of life course perspectives, which are frameworks that can be used to explain how health outcomes change over the life course. The cumulative disadvantage perspective explains the increasing divergence between Black and white health outcomes and focuses on how disadvantages accumulate over the life course. The weathering hypothesis explains the increasing divergence between Black and white health outcomes and focuses on how constant exposure to stress accelerates health decline for Blacks. Now, one of the interesting differences that we saw discussed in the reading is what is called the Latino paradox. The observation that even though Latinos have on average a lower socioeconomic status than whites, they have comparable health outcomes to whites. Latinas without a high school diploma are less likely than white women with a college degree to have a low birth weight baby. How do we explain this? What cultural and structural forces might be at work here? Well, one of the videos that I have listed for you today on Becoming American discusses how assimilating into American culture, poor health and eating habits, results in the decline of these positive outcomes. So what we see in many studies is that when you study immigrant Latinx populations, you see these kinds of better health outcomes for them. But as the next generation, the children assimilate, they start eating fast food, they start getting more into American cultural habits, that we see then an increase in that generation of worse health outcomes. So the clip that I have for you really goes through this and explains very well this particular discrepancy that we see here. And it sort of begs the question, right? Does becoming American make you unhealthy, right? And it's something for us to think about, right? What are the implications of that? The reading also talk about environmental racism as institutional policies and practices that differentially affect the health outcomes or living conditions of people and communities based on race or color. Here in this chart, we see one example showing neighborhoods with hazardous waste facilities called host areas have on average higher percentages of people of color than non-host areas. So when decisions are being made about where to put a hazardous waste facility, more often than not, those decisions are being made to be placed in neighborhoods with poor people of color. The Flint water crisis might be something that you're more familiar with or have heard about, relates to environmental racism. In March 2016, the Flint Water Advisory Task Force report found that the residents of Flint, Michigan, a majority Black and overwhelmingly poor city, had been exposed to environmental and health hazards due to water supply decisions made by city officials. So again, certain decisions were made by city officials about what was okay to do to the water supply of this particular area that would not have been made for middle class, upper middle class white neighborhoods. Another example discussed in the reading is about Native Americans and diabetes. The reading talked about this particular group, the Tohono O'odham and Pima Indians, and I apologize if I'm mispronouncing that, of Southern Arizona, who have the highest rate of type 2 diabetes in the world. However, in 1902, a survey found only one case of diabetes among this population. Yet within 30 years of building the Coolidge Dam, there were over 500 cases. And so what happened was that when constructing this dam, the government cut off irrigation water supply to this population, preventing them from being able to grow their own food, which meant that they had to become dependent on food from the US Commodity Supplemental Food Program, which did not provide healthy options like produce. So once they had to depend on government provided food instead of food that they grew themselves, we saw this healthy turn in their diet and therefore an increase in the number of diabetes. In response to these various environmental racism situations, environmental justice is the response, which refers to efforts to ensure the right to live in non-toxic neighborhoods, regardless of race. Environmental justice movements fight for various causes, including the creation of parks and open spaces, cleanup efforts by toxic waste producers, and clean air and water. So in conclusion, abuses by scientists and medical professions against people of color have existed historically and explain some of the mistrust that is there. Health disparities exist across different medical conditions and racial ethnic groups. And environmental racism contributes significantly to these health disparities. So this ends our lecture for this week. I look forward to seeing your comments in the discussion post.